Good afternoon and happy International Women's Day. Welcome everyone to our very first virtual Women's Care Program tour at London Health Sciences Centre. My name is Tracy Burwell. I am a Development Officer at the London Health Sciences Foundation. And together with my colleagues and our distinguished lineup of presenters, we would like to thank you for joining us. A few things about today's tour. First, everyone's sound is currently muted to protect the sound during the session, and the session is being recorded. Secondly, if at any time today during these presentations you have any questions, please feel free to write them at the Q&A section at the bottom of your screen. We will do our very best to answer these questions live at the conclusion of our tour. Today, we and you are going to experience an exclusive behind-the-scene tour of the Women's Care Program at London Health Sciences Centre. Our lineup today includes 5 presentations, providing you with crucial updates from safer labor and deliveries to incontinence and more. Most importantly, you will hear firsthand the inspiring impact of donor support. Thank you for your generosity and your passion to learn more about the amazing Women's Care Program. So without further ado, let's get started. Our first joint presenters are Dr. Tracy Crumley and Amanda Williams. Dr. Crumley is a practicing obstetrician and the chair chief of the Department of Obstetrics and Gynecology at London Health Sciences Centre and the Schulich School of Medicine and Dentistry at Western University. She studied medicine at Western and completed her OB/GYN residency here at Western before going to Magee Women's Hospital in Pittsburgh for her postgraduate training. When she returned to London in 2003, she was recruited to join the department. She has served on nearly every committee in the department, notably as the Residency Training Program Deputy and Director, the Chair of the Finance Management Committee before becoming Chair of the department in 2018. Jointly presenting with Dr. Crumley is Amanda Williams. Amanda is the director of the Women's Care Program. Amanda trained and worked as a radiation therapist in Wales, UK. She moved to London, Ontario in 1993 to work at the London Regional Cancer Program. Amanda's leadership journey started over a decade ago, and she has worked in several areas, including cancer, children's hospital, and women's care. Amanda has enjoyed touring many donors throughout the years and has spoken and participated at many fundraising events to share the incredible impact that donors have on the patients and families we serve. Now, broadcasting live from one of our birthing units at LHSC, let's give it over to Amanda Williams and Dr. Tracy Crumley.
Thanks, Tracy. Hello and happy International Women's Day. It's very fitting that we're doing this on this particular day. I don't know that we knew that when we started, but welcome. We are very excited to start the evening out today for you. As Tracy mentioned, my name is Tracy Crumley and I'm the Chair Chief of the Department of Obstetrics and Gynecology here at London Health Sciences Centre. I am joining you from one of our birthing rooms here. We have greatly benefited from support from our donors, and we just wanted to show you where this was. Normally in a live tour, I would tour you through this space, but instead you'll get to see it a little bit behind me. Joining me for the introductions, as mentioned, is Amanda Williams. She's the director of our Women's Care Program here at London Health Sciences Centre. The Women's Program encompasses the Department of Obstetrics and Gynecology, Midwifery, and Family Practice Obstetrics groups, as well as supports from pediatrics, cardiology, anesthesia, and psychiatry. We care for women from conception to the end of their lives. We help to conceive through antenatal care, delivery, and postpartum care. And outside of pregnancy, we support women for pediatric, general gynecology, urogynecology, and gynecologic oncology care.
We have an outpatient department that sees over 70,000 patient visits per year, an obstetrical triage department with 13,000 visits per year, and we deliver almost 6,000 babies a year, and had a record-setting July in 2021, where we had 561 births in 1 month. We are a tertiary care OB program, as we specialize in high-risk pregnancies, which accounts for approximately 20 to 30% of all births at LHSC. This means that we provide service to patients that extend far beyond the London Middlesex area, The next closest tertiary care hospital to us is actually in Hamilton. We have over 300 wonderful staff that include nurses, PSWs, aides, clerical staff, clinic assistants, educators, and health disciplines such as social workers, dietitians, and physiotherapists. We have 53 midwives, 30 OB/GYN residents, and 35 consultant obstetrician gynecologists. They all work tirelessly to care for patients and their families, and they support each other while doing this. As you can see from the various professions, this truly is a team approach to patient and family-centered care. Our research serves to advance our knowledge and understanding of best care practices. Our educational program serves 100 medical students per year and graduates 6 obstetrician gynecologists every year who have excellent skills in surgery, delivery, and bedside skills. We regularly have nursing students in both our inpatient and outpatient departments, where they get to learn from experts in the field. They see the complexity and diversity of obstetrics and gynecology firsthand. And many of those students, upon graduation, choose to permanently become part of the team.
Our department has greatly benefited from the generosity of the foundation and our donors. They've supported our equipment needs with lighting for our birthing suites, sleeper chairs, which I am sitting in right now, for the partners while in labor, upgraded ultrasound machines, software to support our antenatal patients, bilirubin blankets for babies with jaundice. They've also contributed to the Patient Assistance Fund, which ensures that no patient is limited in their options for care due to financial hardship. Our donors have contributed to our researchers, to legacy gifts, and gifts in kind. This evening, you will meet Dr. Janine Hudson, a maternal fetal medicine specialist and researcher with a one-of-a-kind program in the country, who's been supported by donor assistance. Dr. Bassem Abu Rafe, a reproductive endocrinologist and director of the Fertility Clinic. Dr. Taryn Taylor, an OB/GYN and PhD researcher with medical education, who leads the simulation education and research associated with the Michael Gunning Simulation Center, which has also been a huge benefactor of the donor program.
You will also meet Martha Gleason, who was one of the first nurses in the women's ambulatory care team to complete the Continence Nurse Advisor training, which led to the inception of a nurse-led continence clinic.
We are so grateful that you have taken the time to join us today, and we are excited to partner with our friends at London Health Sciences Foundation so that we have an opportunity to share with you the impact that the generosity of donors has on the services we provide to families that we are privileged to serve every day.
Thank you. And I will welcome Tracy back.
Thank you, Dr. Crumley and Amanda, very much. Next, I'd like you to meet Dr. Janine Hudson, a clinician researcher leading a new life-changing maternal health research program at London Health Sciences Centre. LHSC welcomes Dr. Hudson to its roster of innovative thinkers. Dr. Hudson grew up locally in Listowel, Ontario, and did her training in the MD, PhD program at the University of Toronto and residency and fellowship in London. She is an assistant professor, gynecologist, and obstetrician specializing in high-risk pregnancies, the Department of Obstetrics and Gynecology and Schulich School of Medicine and Dentistry, Western University. And she was recently appointed to the Department of Pediatrics and joined as a physician with the FRAME Clinic, which is the Fetal Assessment from Maternal Exposure, to counsel pregnant women and healthcare providers on therapeutics in pregnancy. So now, broadcasting live from her office, I bring you Dr. Janine Hudson.
That's great. Thank you, Tracy. So I'm excited to be here and tell you about my research. I apologize for not being able to give a virtual tour from the lab, but we're just having some equipment installed. And finally, just due to COVID delays with some equipment purchasing, we'll be up and running shortly. So hopefully the next virtual tour, I'll be able to show you the great support from donors. So I'd like to thank the donors for their support and allowing me dedicated time to do my research. And I'm very excited to share it with you. So I've prepared a small PowerPoint presentation, which I'll just pull up here. And so I'm going to be talking about the research program that I'm developing together with Dr. Facundo Garcia Bornesen, who's also part of the FRAME Clinic, which is a counseling service locally to counsel women on drug safety in pregnancy. So it stands for Fetal Risk Assessment After Maternal Exposure. And we've been counseling women and identifying drugs where there's no information, and pregnant women may have to take these medications for diseases that they have before going into the pregnancy, or illnesses that they may get once they're pregnant. So 90% of pregnant women actually require medications in pregnancy, and 7 drugs is the average number of drugs that one pregnant woman will take. So it's pretty common in pregnancy, and it's probably a lot more common than people appreciate. I just wanted to illustrate the problem with pregnant women obtaining information about medications. Is recently last fall, acetaminophen was in the news, and pregnant women were urged not to take it because there was an association with fetal development. And this was based on a review by other researchers that had stated that they recommended not to take this, and it created a lot of panic, and there was no good pain medications available for pregnant women to take. And so it left them in a state where they were unable to take anything for pain, and many women were suffering unnecessarily. And so we carefully reviewed the data, and we felt that the use of acetaminophen in pregnancy was safe. And so we published a statement with the Society of Obstetricians and Gynecology of Canada, just reiterating this and really giving pregnant women the support to make the decision to take this without being judged or without feeling that they needed to leave their pain untreated. So there's a lot of vulnerability in pregnant women. There's a lot of information on social media or blogs, and it's really difficult for pregnant women to find a good resource or have the availability of services like talking to their physician. And so that's what the Frame Clinic is used for, is to really give women evidence-based guidance on what medications are okay to take in pregnancy, and to give them the counseling to have them make their decision whether to take medications or not. And so really, we hope that it becomes a discussion, allowing pregnant women to make the choice of whether to take a medication in pregnancy. And this is just the team that we've put together. So the top picture on the right there is Dr. Facundo Garcia Bornacin, who's a pediatrician. And I worked with him during my training in Toronto. And so we've been working together for quite a while. And then at the bottom there is Eddie Chan. So he's our PhD research associate who we've hired to help with the basic science work. And so he'll be specializing in the cellular studies and imaging. And so we have a great team where we can identify pregnant women who I see in clinic, or questions that we get through the Frame Clinic on medications that we can study, bring them back to our laboratory where we can study them using the placental perfusion model, and then bring it back into the clinic using it for counseling and other committee guidelines or national guidelines to really encourage best practices in pregnancy. And so I'll just give you an idea of what the placental perfusion model is. And we'll be the only lab in Canada that's utilizing this model. And it's really being established as a model to better study drug safety in pregnancy. And it's used almost by the FDA. It's almost approved as a way to look at safety of drugs in pregnancy without using animal models. And so it's an up and coming model where we take laboratory data and use modeling and math to kind of come up with the risk of fetal exposure. So just to give you a brief overview, the placenta is the organ that attaches the baby to the mom. It's attached to the uterus, and it has lobules or parts that are each on their own a functional unit. And we take one of those and we perfuse it. And so really we're looking at, if you can see on the left-hand picture where the arrow is, we're looking at studying 5 micrometers, which is very, very small, and how a drug transfers across this membrane using a piece of placental tissue. And because we're using it from humans right at the time of delivery, it's very relevant to human pregnancy. And then we can look at the different ways that it's transferred across the placenta to make decisions about whether it's safe in pregnancy. And so London is the ideal place to do this. We have, as mentioned, we have many deliveries. So we have about 6,000 deliveries per year. And we'll be getting our tissue from scheduled cesarean sections in the morning. And then we'll be walking it over to our lab, which is at the Children's Health Research Institute. And so again, it's just, we're putting it together now with all the equipment. So we should be up and running within the next month. So it's only about a 2 to 5 minute walk, depending if it's raining outside, if you can take the shortcut. And so we can go to the lab very quickly to have that tissue fresh to be able to perfuse it. And the next slide will be a picture of a human placenta. So if you're squeamish, maybe just look away for a minute. So this is the placenta. So that's the umbilical cord that's coming out of the middle there. And those are the fetal vessels that are on the shiny side. That's the side that implants into the mother's uterus. And then we put in tubing into a fetal vein and artery, which is very small. And we put tubing into it where we can then pump cell culture media, or basically to mimic human blood. And we basically mimic what the transfer would be when the baby's inside the womb. So to measure if a woman takes a medication and if it is transferred over to the baby or not. And so this is our chamber. So it's a chamber that we use, and then we set up our tubing. And this is just a schematic of what we'll be doing. And so on the left, you can see we put our medication into a maternal reservoir, which acts like the mom. We put it through a series of pumps and tubing to basically mimic what the circulation is in pregnancy. And then we can take the perfusate from the baby side or the fetal side, and then measure the drugs and measure the kinetics, so how fast it transfers, and make decisions about how much in real life pregnancy would actually go to the baby. And this is a lot of writing, but basically it's showing on the left, we have our placenta or our ex vivo model, and we can get all the mathematical numbers we need from that. And we can combine it with animal studies, because animal studies are needed when a drug is approved. So we can combine that with what drug levels are needed to make toxicity or problems in the developing animal studies. And we can try to see how much the baby in human pregnancy would be exposed to, and make kind of educated decisions or best practice recommendations about drugs in pregnancy, because we don't have studies in pregnancy, or we're unable to study drug safety in pregnancy. So this is a really good model, and it is being adopted by the FDA. And so we'll be doing that right here in London. So a couple drugs that we're going to start off with, hopefully this month, will be the new COVID medications that are up and coming. And these basically have no information on them in pregnancy. And so it's really hard to counsel women about the risk or benefit of taking these medications. So we'll hopefully establish whether the drug is transferred or how it's transferred, and predict toxicity and give them the ability to have proper counseling regarding safety in pregnancy. And the overall goal of this program is to identify drugs or therapeutics where we need to give the mom to treat the mom and baby, while also using the lab to determine if the drug is toxic or if it goes to the baby, so we can also protect the mom and baby. And we'll bring this back to the clinic and our frame clinic, and properly counsel women about medication choices in pregnancy, and also be available to other healthcare providers. And so it's a really translational research program, and we're really excited to get it started here in London. And thank you, donors, and happy International Women's Day. And back to you, Tracy.
Thank you, Dr. Hudson, for that incredibly relevant and exciting update on your research. That is so interesting. Our next presenter is Dr. Taryn Taylor. Dr. Taylor is an assistant professor in the Department of Obstetrics and Gynecology. As one of our lead simulation educators, she designs and deploys highly realistic emergency scenarios for our residents, staff, and midwives and labor and delivery nurses to ensure they're prepared for anything that might happen in real life. Dr. Taylor is also a PhD scientist at the Center for Education and Research and Innovation, where she conducts impactful research that uses interprofessional simulation to enhance team performance and solve real-world problems. This critical work could not be possible without access to the Michael Gunning Simulation Center. And on that note, broadcasting live from the Michael Gunning Simulation Center, I bring you Dr. Taryn Taylor.
Hello, wonderful. Welcome to the Michael Gunning Simulation Center, and welcome to our virtual tour today. We're very fortunate here in women's care to have this simulation center. We're actually, I believe, one of the only centers in the country that has a simulation center that is steps away from our actual labor and delivery unit. So I'm going to give you a behind the scenes tour here. You'll see some things that most of our participants don't even get to see when they come to us. We're very fortunate that we're able to welcome welcome midwives, family practice OBs, obstetricians, residents, medical students, and of course, our labor and delivery nurses to come to the center here and practice their skills, not only technical skills, but also, how to function as a high performing team. And so you'll see behind me here is our debriefing room, and we're going to end the tour there. But let's take a sneak peek at our control room. Again, this is a place that not many people get to go. I spend most of my time here when we're running our simulations. This is where we are able to, generate the changes in vital signs for our mannequin or sim mom, who is our high fidelity simulator, and I'll introduce you to her in a moment. But behind the scenes here, we're playing the roles where we've got the voice of sim mom. We're making sure that we're watching through the two-way mirror here, how our participants are actually engaging with the scenario. There's a lot of improvisation that has to happen, just like in real life, for sure. So this is where we sort of enact the plans that we've made when we design the simulations to allow our participants to experience a real life experience. We try to aim for realism so that they really feel like they're in a true obstetrical emergency, like a postpartum hemorrhage or a maternal cardiac arrest, as a couple of examples of the scenarios that we've run recently. So without further ado, I will introduce you to sim mom. So follow me here. So one of the great things about the Michael Gunning Simulation Center is that we are able to essentially replicate one of those labor and delivery rooms that Dr. Crumley was speaking from earlier. So we have our sim mom, as well as some of our equipment that we would normally have, and of course the vital signs for sim mom as well. But you can see sim mom is quite high tech here. She actually has chest rise and fall. You can listen to heart sounds. You can palpate pulses. As I said earlier, we usually voice her from the control room there. This is obviously the most important part of sim mom. This is where her uterus is held. I don't know if you can hear, there's a motor inside here, and sim mom's actually able to deliver her own baby. She can deliver a baby who is coming out the vagina head first. She can also deliver a baby that is breech. So let's take a look and see here. We'll just get sim mom all set up here. I better get my gloves on quickly. This feels very real to life. All right. So as I said earlier, sim mom is able to deliver her own baby. She has a special hydraulic system inside. And so this allows our participants to actually, practice their skills in assessing for fetal position. They are able to check for, their sort of technique in safely delivering a baby vaginally. We can also, with a special module, replicate an obstetrical emergency called shoulder dystocia. So a shoulder dystocia is when the baby's shoulder gets stuck underneath the pubic bone. Oh, here we go. All right. We'll see here. Good job, sim mom. There we go. Fabulous. And keep pushing there. All right. There we go. Oh, there we go. Well done. Fabulous. All right. So we're going to move over into the debriefing room now. I'll get my gloves off here. I did want to also share one other really special part about the Michael Gunning Simulation Center and the resources we have here, is that while it is very convenient, we can bring people to the Sim Center, we also have the resources to kind of bring simulation to the people. And that is called in situ simulation. And that's something that we actually run in situ simulation in the real hospital setting. So rather than in the sim lab, we actually design scenarios that are intended to take place in and around the hospital. So when COVID first struck, we realized there was a huge volume of information. It was hard to keep up with all the recommendations and the evidence as it was emerging. And so in order to ensure that we were providing the best possible and safest patient care for patients presenting with COVID or suspected to have COVID, we designed some scenarios. We used sim mom and we actually dressed her up We put a GoPro camera on her forehead. We brought her down to the entrance of the hospital, and we ran a scenario that began at the periphery and ran all the way through up to our obstetrical triage department into one of our birthing rooms. And basically the scenario was, what do we do with a laboring pregnant patient who might have COVID? And we learned so much from that experience. We had everyone participating as if this was a real life patient. And so that meant that we were able to discover some safety threats that we would not have wanted to learn the first time around with a real life patient. And so again, that's the benefit of simulation. We learn things, important things, when the stakes are very low and we're dealing with a mannequin rather than a real life patient. And then we can translate those skills and those insights and those sort of safety threats that we've identified. We can actually implement policies and procedures and training to ensure that that doesn't happen when we're looking after our own patients. So I wanted to share with you a few highlights of what the Simulation Center has been up to over the last year. So as you can see here, we've actually had over almost 2,000 learners coming into the Sim Center. And again, these are from a number of different professions and disciplines, all coming together to practice their interprofessional team skills. We also have a number of research programs ongoing here, collaborations, both within obstetrics, but also with cardiology. We've had 80 research participants come through, again, through all of those disciplines. We've got 4 manuscripts in progress and 7 abstracts that are going to be presented at both international and national conferences. We do ask for feedback from our learners. And so I just wanted to close by sharing a brief testimonial from one of our participants who actually came to the Simulation Center as a learner and is now practicing in the community hospital. She said that simulation provides an opportunity to learn about the serious, unusual cases within a culture of safety. I feel quite lucky to have trained in a setting with simulation expertise and experiences integrated into my learning, and then to have seen the benefits of simulation for ongoing continuing medical education and quality improvement in any practice setting. So once again, I want to extend a heartfelt thank you to our donors, without which this would absolutely not be possible. And I will pass it back over to Tracy. Thank you.
Thank you so much, Dr. Taylor. It was lovely to meet Sim Mom, and so interesting to hear how the Michael Gunning Simulation Center helps improve and the impact it has on patient care. Thank you very much. Friendly reminder, if you have any questions, we encourage you to jot them down in the Q&A section at the bottom of your screen so we can answer them for you live at the end of the tour. Our next presenter is Dr. Bassem Abu Rafia. Dr. Abu Rafia is an associate professor, division chief of reproductive endocrinology and infertility at the Department of Obstetrics and Gynecology, and is the medical director of the Fertility Clinic. Dr. Abu Rafia has a passion for research. He has authored and co-authored more than 70 articles in peer-reviewed journals, 2 book chapters, and completed more than 70 abstracts and presentations. His current research is centered on embryo development and selection in single embryo transfer, advances in minimally invasive surgery, and improved treatments for abnormal uterine bleeding. Without further ado, and now broadcasting live from his office, I pass the baton over to Dr. Abu Rafia.
Hello, good afternoon, everyone. First of all, I'd like to thank everyone for being here today, and take this opportunity to always thank our donors for their continuous support in all the help they provide and the progress that we have at our institution. Today, I'll be talking a little bit about another simulation program, and Dr. Taylor has given an interesting, a really great introduction to the world of simulation, which I think is going to be the world of the future. And just to start off with a little bit of background of what we do at our fertility clinic here at London Health Sciences Centre. This is a drawing of Dr. Plunkett, and I'm not sure if people are aware of Dr. Plunkett, but Dr. Plunkett was one of the first, he was the founder of the fertility program back in the mid-70s and was a previous chairman of the department, and one of the discoverers of a key component that helped establish the first birth control pill. I don't know if a lot of people know that, but this came from London Health Sciences and Western. Also, London hosted the first IVF clinic in Canada, and we were also the first Royal College recognized fellowship subspecialty training site in Canada. So there's a lot of firsts that are established at this institution. And this is aided by the long-standing collaboration between London Health Sciences and Western. Now, what we do at our institution is divided mainly into two components. There's a clinical service component, there's an academic component, and they really intermingle deeply and heavily. So the clinical aspect, just to give a little bit of an idea, basically hovers around what's called assisted reproductive technology. And in that case, I think most people are familiar with the world of IVF and in vitro fertilization, where we help couples who are unable to have children through natural means achieve their objectives through retrieving the patient's eggs, fertilizing them with sperm, and transferring embryos. And we perform approximately 500 IVF cycles a year at the center. We do also approximately 1,000 intrauterine inseminations. We assess about 2,000 fertility patients per year. And this is mainly the bulk of our work. We also offer reproductive surgery, which is unique to London Health Sciences Centre Fertility Clinic because it's all in-house. So we deal with things like uterine fibroids or endometriosis, which are conditions that can negatively impact patients' fertility potential and as such help optimize their success rates. We also house what's referred to as the Early Pregnancy Assessment Unit, which was the first clinic established approximately 20 years ago here at LHSC that looks after complications of early pregnancy up to 14 weeks gestation. We see approximately 3,000 patients in this clinic where any early pregnancy related problem is dealt with at our site other than the emergency department. Now, what we do academically is reflected in this picture, which holds different members of the department or at different times. We have physicians who are retired, we have physicians who are in training, but also demonstrates or shows nursing who are trained here and our scientists who are also part of what we do. So we don't only work with physicians, but we work with basic scientists and we work with nurses. And this was a picture taken pre-COVID from a Canadian Fertility Society meeting where we won several awards at the time. Now, what we face in our challenge and what we do is trying to improve our training at all times. And we at London Health Sciences Centre have been training specialists in the field of infertility since the mid-80s. And the training has always been, I think this is a common caricature, just shows that see one, do one, teach one. So the trainees in our field had to observe for a prolonged period of time and then under supervision perform the procedure before they were deemed competent to move on to performing it on their own. And as such, the patient was the training vessel. And unfortunately, there's no other way around that until recent breakthroughs in technology. So this has always been the challenge, and we've always tried to improve that area. We train right now 2 fellows per year. So just to give you an idea of what we're focusing on with regards to training, this is a diagram showing an egg retrieval, and here you can see a transvaginal ultrasound probe with a needle that goes through the vagina into the ovary to aspirate the egg, which is then suctioned into the tube and taken to the lab for fertilization. This process is highly complicated, it requires lots of training, and the fellow at this time has to do hundreds of ultrasounds before they're able to attempt one of these procedures. Just to give an idea of how big that needle is, because I don't think that diagram represents it, it is really big, and it is extremely important that whoever's doing this is extremely competent, because there's a lot of sensitive organs and structures in the pelvis, and we do not want any injuries occurring. The other important part of what we do is transferring the embryo. So after the egg is retrieved and fertilized by the sperm, embryos are developed in incubators, and once they're ready, they are transferred back into the womb of the carrying patient or mother. And this transfer is done under ultrasound guidance and is the most critical step of the whole process. There's been ample studies about how technique makes a big difference. And this process or this step represents a major challenge in training. To give an example, approximately 50% of American trained fellows finish their 3 years of fellowship only having done 10 of these transfers. Now, just to put things in perspective, our fellows finish their training having done over 500. So despite this, our fellows are training on our patients, and we would like to look at ways to help improve that process. So when we do graduate them, we know they are solid and they will serve their community and their patients well. Now, we've known for a long time that simulation has been very successful, and the leaders in this have always been the airline industry. However, in our field of reproductive sciences and infertility, only recently did simulators come out, and even then they're very new, and therefore it's not yet a fully established area, but it is progressing rapidly. This is a picture of the egg retrieval simulator, which a fellow or trainee would be able to practice multiple times prior to actually attempting to introduce that long needle into a patient's pelvis. And therefore, this would hopefully speed up and improve their competency in doing their procedure. This is another simulator that was recently developed by the American Society of Reproductive Medicine that looks specifically at embryo transfer, and it mimics various difficulty levels in doing so. This was also studied in a recent paper published by the American Society of Reproductive Medicine, demonstrated that there has been a significant improvement in the competency of the trainees when they have used a simulation prior to moving on to real life procedures. So our vision here is to look at establishing the first reproductive endocrinology simulation program in Canada. This, I believe, is possible because of the unique setup that we have at London Health Sciences Centre and its collaboration with academia, and the generous support that we usually have from all our donors and the institution. This would also set us up to be hopefully regional, if not a national training center, which may be hopefully reproduced at other locations. The impact of this, if we use previous models of simulation, will be expected to reflect an improved quality of care that's provided to our families that pass through their journey through LHSC to start their own family. So at the end of the day, you've seen talks about babies being delivered. This is kind of where we make them or help people start their families. And if you're ever wondering what we're doing when we're not doing that, you're welcome to join us to practice for the Dragon Boat Racing, where we support breast cancer survivors and breast cancer patients. And I thank you all for listening to me today, and happy International Women's Day, and stay safe.
Thank you, Dr. Abu Rafia. How fitting it would be, LHSC being the first in Canada with the in vitro clinic, with the fertility clinic, and then WOW to potentially be the first in Canada with the REI Simulation Center. So exciting. Thank you. Our next presenter and our final presenter, yes, we saved the best for last, is Martha Gleason. Martha has enjoyed being a registered nurse in women's care for over 15 years. Martha completed the Nurse Continence Advisor Program at McMaster University and has been a lead role in planning and implementation of the Continence Clinic. So broadcasting live from the Continence Clinic at the London Health Sciences Centre, everyone, I'd like you to meet Martha.
All right. Well, welcome to the Continence Clinic. That's quite an introduction that I have to live up to. So the Continence Clinic started in 2018. And right now we have 2 nurses who are educated and trained. We run 1 day a week. And we see about 7 to 8 patients per day. Typically, these patients that we see have stress incontinence, meaning these women have, they leak when they do, daily living. So it becomes quite a hindrance to them. Their quality of life tends to decline. So we see them and we provide them with strategies that can help improve their incontinence, therefore improving their quality of life. Typically, these patients would wait up to about 2 years for an appointment with a urogynecologist. So now they would wait about 3 to 4 months is our wait time. Usually, these patients have about up to 12 appointments. When we see them, we assess them, and we provide them with strategies. One of them being biofeedback, which I'll show you the machine. We've seen about 500 new patients since we started. That translate to about 4,000 appointments since 2018. Donors have provided the education for the nurses, and they have provided equipment. The equipment that they provided is our bed, which you can see in the background, which we use for the continence clinic, as well as the urodynamic study testing that we do for the urogynecologist. And I think we received 2 bladder scanners and the biofeedback machine. So the biofeedback is what we use typically for most women who come and have stress incontinence. This biofeedback is 6 appointments, 1 week apart, and it includes the women. They put a probe in, and you can see that they follow a fish. So it's kind of like Pac-Man with your vagina, basically. That's the easiest way to describe it. Women tend to see an improvement in about 3 to 4 weeks. And we have had women who continue to come because it has changed their lives. Some women have come because they were told by their physician that they may require surgery. This can help with surgery as well. It can, if we're talking surgery, we're talking about a patient who may have a prolapse. While this will not take the prolapse away, it strengthen the pelvic floor in order to keep the prolapse up. So again, this is our biofeedback machine. Women, like I said, have been coming for a very long time doing this. They finish their 6 weeks and they tend to like to return generally like once a month, once every 3 to 4 months, just to kind of touch base to make sure that they're still doing their Kegels properly. We have a bunch of patients who have given us testimonials. I just want to read you one. Before coming to this clinic, my bladder was controlling my life. And now after 6 weeks of biofeedback, I'm in control of my bladder, and this clinic has changed my life. So that's our clinic in a nutshell. And back to you, Tracy.
Thank you so much, Martha. That was fantastic. Thank you, Dr. Crumley, Amanda Williams, Dr. Hudson, Dr. Taylor, Dr. Abu Rafia, and Martha for your amazing presentations and your time. It's been a delight just seeing even this small glimpse of our amazing women's care program at LHSC. And that concludes the formal presentations. And now we're going to move into the question and answer portion. I welcome everyone back, and Dr. Crumley and Amanda, if you can assist with the delegation of those who could best answer these questions. I'm thinking, though, the questions are posed so perfectly, I'm pretty sure I can see who best to answer them. But Amanda and Tracy, we'll start with this. We have a question about fellows. How many fellows do you have each year in the women's program? And the question then asks, do the fellows stay in London after you train them? And how would someone qualify? So how many fellows approximately do we have each year in the women's program?
So we have fellows in a variety of subspecialty training programs. We currently have 2 fellows in maternal fetal medicine and high-risk obstetrics. We have 3 fellows in urogynecology, which relates to the continence clinic. And right now in the fertility program, Dr. Aburafe could correct me, I think there are 4. So we often have a grouping of residents that go through every year in the variety of different specialties. These are individuals who have completed their obstetrics and gynecology residency training. So they are fully qualified OBGYNs who are then doing subspecialty training in these areas. And so certainly they benefit from all of these programs that we've been talking about prior. In terms of staying on, a number of our fellows who have been excellent do end up staying on. So Dr. Hudson, Dr. Taylor, and Dr. Aburafe are all former residents who then did training here and stayed. So excellent people. We do try to keep them around if we can at all.
Great. And Dr. Crumley, did we address how someone qualifies to be a fellow?
So they have to do a OBGYN residency training program, complete that. It doesn't have to be Canadian. We do have international fellows as well, but somebody who is a fully qualified OBGYN would be required before they could come to do a fellowship.
Okay, thank you so much. Have you ever had a situation where you used the simulator for birth and particular scenarios and then had the actual scenario happen? The training saved the day, so to speak? That's a great question.
Yes, Dr. Taylor might want to answer that one, but absolutely, that's why we do it.
Absolutely, yes, that happens eerily more often than you would think. So I can think of examples off the top of my head where we've run a postpartum hemorrhage situation, and part of the scenario we specifically, one of our learning objectives is to make sure that when our participants leave, they are comfortable putting together a particular tool that we use called a Bakri balloon. And it's actually a little bit trickier than you'd think and than most people think. So I often find when they're in the simulation, they struggle with it quite a bit. And then we finish the scenario, and as part of our debrief, we go through how to do it. I've had many people come up to me afterwards and say, I'm so glad I did that sim. We had a postpartum hemorrhage, during my next shift, and we needed to use a Bakri, and like I was the one that could put it together swiftly. Certainly with all of our COVID in situ simulations, it was unfortunately happening more often than we would have liked, where we would run a simulation, learn a whole bunch of things, and quickly pivot to implement new procedures and policies. And then it would happen, a week later, where we'd have a COVID positive patient come in laboring to triage and need an urgent intervention like cesarean section. And so, the trainees that were part of that in situ sim were able to particularly benefit, whereas they were more comfortable putting on their PPE and certainly knowing how to get the patient safely through from triage into the C-section suite without, compromising other patients along the way as well. So it does happen remarkably often.
Wow, thank you for that. How old is SimMom? And are there any plans to enhance and expand the Michael Gunning Simulation Center program?
So SimMom came to us in 2019, so she's 3 years old. There are absolutely plans to expand the Michael Gunning Simulation Center and our simulation program in women's care. We've already been fortunate enough in this past year to bring our midwives into the Sim Center. A lot of our midwives actually use the Simulation Center to expand their scope of practice so that they're able to safely support patients who are laboring with an epidural, as well as support patients using oxytocin. I think the main vision for the future is to get more folks into the Sim Center, make sure that we're doing more interprofessional collaborations. We have a number of research projects that are going to be continuing to expand as well, to make sure that we have learning not only for our center, but that we're able to disseminate this knowledge to other centers across the country and even around the world.
Thank you. And this is the last question, I think, for you, Dr. Taylor. How many different scenarios do you think SimMom did in 2021, like in an average year, if you were to guess?
That's a great question. I don't know if I could put a number on it because SimMom's busy, as is our simulation center here. I mean, COVID certainly meant that we had to be very particular about how many people were safely able to be within the simulation center. And so that meant certainly a few less people than we would have normally liked. But in an average year, we would run one interprofessional simulation day for our OB, anesthesia, and nursing colleagues every month. And so that involves between kind of 6 and 10 participants per day. And then on top of that, we have our in situ simulations, which we would usually run 3 to 4 times a year. And that often involves between, I would say, 30 and 40 individuals because we run them through the hospital. So that includes folks that are in our obstetrical care unit. But if the scenario allows, we would also travel to our, CCTC, our ICU. And then we're involving nurses and participants from there as well. So I couldn't put a hard and fast number on it, but we're hoping to just keep being busier and busier and making sure that we're serving the population here and that they feel equipped to be, a really enhanced interprofessional team when they're looking after real patients.
Thank you very much. And our final question is regarding the future vision for the fertility clinic and making it a first in Canada, offering it as a simulation center. The question is, how expensive is the simulation training equipment?
So the equipment, there are two parts to the equipment. One device that actually is American manufactured. The other one comes from a small town in Italy. And I don't know why the Italians did the research, but they have a wonderful product. I believe their version of their for the egg retrieval simulator is approximately I think 30 or 40,000 euros. And this was a year ago when we quoted it. And the embryo transfer simulator from the United States is 75,000 US dollars.
Okay, thank you so very much. Thank you for all those awesome questions. This concludes our tour. On behalf of my colleagues, thank you for joining us. We wish everyone a fantastic evening. Bye.